Hello everybody, hope you all are fine. The topic under discussion for today is development of FOREGUT and its anomalies part 3. So at the end of this session, the participant should be able to discuss various malformations of the stomach, describe the morphogenesis of the duodenum, and discuss the malformations of the duodenum. We start with the stomach malformations. These malformations are least encountered as regard the GI tract and are seen 10 to 30 per 1 million newborns. There are three types: stomach atresia, stomach stenosis, and wall duplication or cyst. First, the stomach atresia. This type of malformation generally occurs in antrum or pyloric region of the stomach, and there are three types. First one is the mucosal atresia, which is present as a membrane or a septum. It may be complete or incomplete and is the most common type of all the three. It presents during neonatal life, and depending upon the degree of gastric outlet obstruction, it may consist of gastric mucosa, submucosa, and muscularis mucosae. Second variety of atresia is fibrous band. This is a segmental defect which is bridged by a remnant of fibrous tissue cord. It generally lacks mucosal element but contains normal serosal and muscular layers. Third variety is complete segmental defect. This presents with a gap between the two parts of the stomach. Second type of stomach malformation is the pyloric stenosis. This is present as a reduced lumen of the pylorus, which is because of a hypertrophy of the sphincter muscles of the pylorus. This is the most common abnormality of the stomach and is more frequently seen in males than females and presents within 4 to 5 days of postnatal life. Recent research shows that postnatal erythromycin treatment can cause this type of malformation. This malformation obstructs the passage of food, hence presents with severe projectile vomiting. Third type of stomach malformation is duplication of the stomach, which can be complete or partial duplication. These are also named as gastric duplication cysts. These are very rarely seen, and these represents only 4 to 9% of all the GIT duplications. Majority of the duplication in the stomach occur along the greater curvature, and usually they present as circular, non-communicating, and surrounded by a smooth muscle coat. Now we start with the development of the duodenum. Duodenum develops from the caudal part of the foregut and cephalic part of the midgut, and the junction between the two lies just distal to the liver bud. Duodenum grows rapidly and forms a C-shaped duodenal loop, which initially projects ventrally in the midline. This looping of the duodenum occurs because of number one, differential growth of the gut wall. Number two, development and positional changes of the adjacent structures like rapid growth of the head of the pancreas, rotation of the stomach, and all this effect, that is rapid growth of the head of pancreas and rotation of the stomach, leads to the positional change of the duodenum, that is duodenum swings towards the right side. Duodenum along with pancreas and their mesentery lie in the dorsal mesogastrium. It swings and presses against the parietal peritoneum lining the posterior abdominal wall. Hence, adjacent layers of peritoneal folds are absorbed, leading to the retroperitoneal position of the pancreas as well as the duodenum. Now, something about ventral mesoduodenum, which almost disappear, but a small part, that is proximal part between liver and first part of duodenum persists and forms the hepatoduodenal ligament. This ligament forms the free border of the lesser omentum and contains hepatic artery, bile duct, and portal vein. During week 5th to 6th, initially lumen is obliterated temporarily by proliferation of the epithelial cells lining its lumen. This is named as epithelial plug. Process of vacuolization and recanalization occurs in the plug, and in normal cases lumen is reformed by the end of embryonic period. Because of its dual origin, duodenum receives dual blood supply. Foregut area is supplied by celiac artery and midgut area by superior mesenteric artery. Most of the malformations of the duodenum are because of inappropriate recanalization process in the epithelial plug. If there is no vacuole or less vacuole formation in the epithelial plug, this leads to inadequate recanalization, and the result is number one, atresia. In this condition, there is no lumen and the lumen is occupied by a septum. Hence, the proximal segment of the duodenum becomes dilated and the distal segment remains underdeveloped. Second is the stenosis. In this condition, there is narrowing of the lumen because of incomplete recanalization process, which leads to incomplete obstruction of the duodenum. Hence, there is dilatation of the proximal segment, whereas the distal segment remains unaffected. Comments and suggestions will be welcomed. Thank you for listening and watching.